Hello everyone, I am Sarinya Kongpetch. I'm from Cholangiocarcinoma Research Institute, Khon University, Thailand. Today I'm going to give the talk on the topic novel genomic opportunities, BAP1, CDK, and ARID1A. As the genomic study using the various next-gen sequencing modalities expand the treatment option for CCA. As many of you know that the FGFR2 and IDH1 are the best understood target to date. However, the many more novel genomic opportunity that I'm gonna give you the detail today is about loss of function mutations in epigenetic factors, including ARID1A and BAP1. Aberration of the cell cycle and the role of CDK inhibitors also will be reviewed today. So start with the 2013 where the back-to-back publication on Nature Genetics report about the mutation of chromatin remodeling genes in cholangiocarcinoma. Look at the first publication here. Among the chromatin remodeling genes, the BAP1 showed the highest frequency, about 25%, followed with the ARID1A, PBRM1, and IDH alterations. The second paper was published to show the mutation pattern between two groups, non-OVCCA and the OVCCA. If you look here, you will see that the BAP1, BAP1, IDH1, IDH2 were more frequently mutated in the OVCCA, whereas ARID1A are highly mutated in OVCCA. This point out the different etiological factors contributing to the CCA tumorigenesis. And then it's confirmed together with this publication in 2013 with the genetic alterations associated with the methylation phenotypes in different groups of the CCA that show the hypermethylations. And this hypermethylation may gain beneficial effects from epigenetic drugs. Look at the cluster 1 with hypermethylation, mostly the tumor also from liver fluke-related CCA that show the hypermethylation with the enrich of the low expression of TET1 and high expression of EZH2, whereas in cluster 4 with hypermethylation, almost in the non-liver fluke-related CCA, also enriched with BAP1 and IDH alterations. This also suggests the alteration associated with the methylation phenotype in the different etiological CCA. Talking about BAP1 or BRCA1 associated protein 1 is a deubiquitinase enzyme. Somatic mutations in BAP1 have been identified in several types of human cancers. Somatic mutation of BAP1 in CCA fall about 7 to 25%. The role of BAP1 shown as the tumor suppressor in intrahepatic cholangiocarcinoma. Look at this graph. The BAP1 loss is associated with the lymph node metastasis and associated with the poor overall survival in the intrahepatic cholangiocarcinoma. This also supports with the in vivo model where the overexpression of BAP1 significantly suppress the ICC tumor progression in vivo. In mesothelioma models, BAP1 mutants are sensitive to EZH2 inhibitions. This result suggests a novel therapeutic approach to use the EZH2 inhibitions for BAP1 mutant malignancy, including CCA as well. And EZH2 inhibitor has been evaluated in clinical trial as the monotherapy in adults with relapsed or refractory malignant mesothelioma with BAP1 inactivations. And the epigenome study also suggests that the frequent loss of function mutations in epigenetic factors such as ARID1A, BAP1 are likely to elicit to the EZH2 addict situation. Look at this figure. You will see the balance control between each antagonism between the polycomb C and polycomb C2 and EZH2. With the Swiss complex ARID1A, BAP1, and KTM6A. To be eligible target for EZH2 inhibitors, the cancer must gain off function of EZH2 by upregulation or overexpression, or the cancer must have loss of function in ARID1A or BAP1, which is the antagonistic molecule for EZH2. This comes with the idea of the synthetic lethality, where EZH2 inhibitor does not affect the normal SNP cells, but in the cancer event where loss of functional SNP subunit, for example, loss of ARID1A, may lead to SNP deficiency in the cancer cells and relying on the polycomb2 for survival. This will prone to epigenetic antagonism such as EZH2 inhibitor that may cause the cancer cell to stop to grow and also induce the cancer cell death. The small molecule inhibitor enzymatic activity of the EZH2 have been translated into the early phase clinical trials. This is the summary table between epigenetic antagonism and the synthetic lethal relationships. For example, in ARID1A deficiency, the functional interplay with the PITK-AKT pathway and the loss of ARID1A cancer can treat with the AKT inhibitors, and they are on the clinical trials. In the BAP1 deficiency case as well, functional interplay with the EZH2 inhibitions also ongoing in the clinical trials as the monotherapy. Talking about the ARID1A in CCA, the ARID1A is the AT-rich interaction domain 1. It encodes as an accessory subunit in the SNP chromatin remodeling complex. This complex plays a role in regulating gene transcription. Among the SNP subunit here, ARID1A showed the highest mutation rate in human cancers, especially over 50% of ovarian clear cell carcinoma have ARID1A mutation. In CCA, the somatic mutation in ARID1A are about 17 to 19%, mostly are truncating mutations, and the suppressive role of ARID1A on the CCA cell proliferation are showing here. Apart from the role of the anti-proliferations, 61% of the CCA tumor with low ARID1A expression also show the significantly associated with the distant metastasis. This supports the role of ARID1A as the tumor suppressor in the CCA tumorigenesis. The treatment implication for patients with ARID1A loss may be using the EZH2 inhibitor as shown here. The ARID1A mutated cancers are sensitive to the EZH2 methyltransferase inhibitions. Using the EZH2 inhibitors cause the regression and reduce the number of the tumor nodules in the ARID1A mutated OCC tumors. And also the treatment implication to use the AKT inhibitor in the ARID1A loss cell line. The AKT inhibition is an effective treatment strategy in ARID1A deficient gastric cancer cells. As you've seen here, using the AKT inhibitor can suppress the cell viability and induce apoptotic cell death, suggests that loss of ARID1A expression is a surrogate marker for the activation of the AKT signaling pathway. Come to the cyclin-dependent kinase or CDK. As you know, the cell cycle regulatory process is frequently disrupted in cancer, providing a rational target for therapeutic development. This is the cell cycle. If we expand in the G1 phase, the key player will be the cyclin D and CDK. If cyclin D is complex with the CDK, it will phosphorylate at the RB protein, release of the E2F transcription factor, leading to the cell dividing. To block with the activation here using the CDK inhibitors can block or interrupt the cell cycle at G1 phase and inhibit the cancer progression. But to use the CDK inhibitor must have the intact RB to make the cell is more susceptible to the drugs. And at least 3 CDK inhibitors are FDA approved to use for advanced breast cancer with hormone receptor positive. This is the paper show the role of the CDK inhibitor in the cholangiocarcinoma. CCA tissue express high levels of the cyclin D1 and the specific marker for CDK activity, phosphor-Rb. In most of the CCA cells here, the CDK inhibitor suppress growth rate with the promote G1 arrest and induce the cancer cell senescence. The effective CDK inhibition for CCA was confirmed using the 3D spheroid xenograft model as well as the patient-derived xenograft model. And the paper also suggests the sensitivity of the CCA to the CDK inhibition is associated with the activated KRAS signatures. This can be implied that in the CCA patient with the KRAS mutation also may be sensitive with the CDK inhibitors. And they also show the list of the genes that can use as the predictor for the response to the CDK inhibitor as well. So come to my summary. The opportunity, you will see that the information here will give the opportunity for the CCA patients harboring mutations in the epigenetic factors, focusing on the ARID1A and BAP1. ARID1A mutated cancer are sensitive to the EZH2 methyltransferase inhibition. And EZH2 inhibitors have been evaluating in an early phase clinical trials for cancer with loss of BAP1 function as well. The CDK inhibitors are now approved by US FDA to use for advanced metastatic breast cancer. So it may be the opportunity for CCA as well to use the CDK inhibitor in the CCAs that depend on the CDK activity and to use the CDK and phosphor-Rb pathway as the therapeutic target for CCA treatment. So that's all of my presentation, and I would like to thank the Cholangiocarcinoma Foundation for inviting me to give a talk for today. So that's all. Thank you for your attention.